Good day everyone, I am Winbrent M. Corpus, your lecturer for week number 3 for Hematology 2 lecture MLS 417. For this week, we will be discussing about anemia of bone marrow failure. So the reference book for this topic would be the lecture notes and Rodak's Hematology Clinical Principles. Basically, the objectives of this discussion for anemia of bone marrow failure is to describe the types of anemia of bone marrow failure and how to diagnose them using laboratory parameters, and also will give the treatment and prognosis for each of the bone marrow failure types of anemia. So before discussing the anemia of bone marrow failure, let me introduce to you the bone marrow. So we know that the bone marrow is the primary site of hematopoiesis. When we say hematopoiesis, this is the blood cell formation. We have the red blood cell formation, the white blood cell formation, and the platelet formation. So it is in the bone marrow that all blood cells are made. So these blood cells include, as I've said earlier, which is the oxygen-carrying transporter, which are the RBCs. The one responsible for the hemostasis would be the platelets, and the body's army, which defend against infection and diseases, which are the leukocytes or the white blood cells. So basically, the bone marrow makes all the blood cells needed to keep the body healthy for surveillance of cancer cells and etc. So I think this term is familiar to you, the pancytopenia, in which it is defined as any condition resulting to a defect in the bone marrow and results to a reduction in the bone marrow's capacity to produce blood cells, the red blood cells, the white blood cells, and the platelets, which eventually will result to pancytopenia in the CBC result. So again, pancytopenia is defined as reduction of all cells, blood cell types in the bone marrow. So pancytopenia is seen in most cases of bone marrow failure, particularly in advanced or severe cases. So as shown in the rightmost portion of this slide, on the top portion here is an example of your aplastic bone marrow in which there is infiltration of more adipose tissue or adipocyte than the cellular components of the red marrow. So as you can see below, here is the normal picture of the bone marrow in which there are abundant cellular precursors which will produce erythrocyte, leukocyte, and thrombocyte, and will eventually produce mature ones, RBC, WBC, and platelets. So on the previous slide, I've mentioned about the term aplastic anemia. So in this slide, this is the bone marrow biopsy of an aplastic anemic patient in which it depicts reduction or marked reduction in the amount of hematopoietic precursor or hematopoietic tissues, which eventually will result to deficient production of the blood cells in the absence of bone marrow infiltrative process or increase in reticulin. However, if there are presence of bone marrow infiltration, so that would be termed as myelodysplastic or myeloplasic type of anemia. So that will be discussed on the proceeding slides. So shown in here are the general pathophysiology of anemia of bone marrow failure, in which we have 6 mechanisms. So first, the destruction of the hematopoietic stem cells by exogenous substances such as drugs, chemicals, radiation, viruses, or it could be also from endogenous in which there is autoimmune mechanism. Second would be premature senescence and apoptosis of hematopoietic stem cells due to genetic mutations. Next would be the disruption of the bone marrow microenvironment that supports hematopoiesis. Fourth, we have ineffective hematopoiesis due to stem cell mutation, or we have the nutrients that are essential for hematopoiesis, in which we have vitamin B12, or we have folic acid deficiency. Fifth, we have decreased production of hematopoietic growth factors and other related hormones which promote red cell blood or white blood cell or red cell or platelet formation. And sixth would be the loss of normal hematopoietic tissue due to infiltration of the marrow space with abnormal cells. After discussing about the pathophysiology of the development of anemia of bone marrow failure, so we have to know how we diagnose aplastic anemia or disorders of the bone marrow or bone marrow failure. So we have BMA, or the bone marrow aspiration, in which, as you can see on the rightmost image, it is usually performed on the posterior iliac crest, in which we are applying anesthesia, since this is very painful procedure, given on the site of puncture to reduce the surface pain. We could also get samples of bone marrow aspirate from the sternum. However, during these days, it is much more common to perform it on the posterior iliac crest. So when we say aspiration, it means that the doctor or the physician somehow sucks some bone marrow cells using a syringe. So there are also other ways on how to get bone marrow from the bone. So we also have, as you can see, my color blue and color green. That's what we call the bone marrow trephine, in which we remove 1 or 2 cm core of the bone marrow in one piece. So the purpose of this is to um, assess the bone marrow architecture and cellularity for the bone marrow biopsy. For the bone marrow aspiration, this only allows us detect any abnormal cells, but doesn't assess the bone marrow architecture. So what's the importance of having bone marrow aspiration or bone marrow biopsy? So this is used to measure the myeloid to erythrocyte ratio, in which the ME ratio is the numeric expression comparing the relative number between the myeloid or the granulocytic precursors with relative erythroid precursors in the bone marrow. So how do we know if we are having infection, or we are having leukemia, or we are just having a normal ME ratio? So for the normal ME ratio, it is usually 2:1 to 4:1, with an average ME ratio of 3:1. So when there are infection present in the body involving the bone marrow, it is usually increased up to 6:1. When there is a presence of leukemia, it could rise up to 25:1. So now let's proceed with the discussion of the aplastic anemia. So the characteristic of aplastic anemia are the following. We have pancytopenia, in which we have reduction in the amount of hematopoietic tissues that result to deficient production of blood cells in the absence of bone marrow infiltrative process or increased reticulin. So we also have reticulocytopenia. We have bone marrow hypocellularity, meaning there is decreased level of hematopoietic tissues, and then also depletion of hematopoietic stem cells or precursor cells, and there would be absence of immature cells, since there is depletion of stem cells. Another characteristic or unique characteristic of aplastic anemia is the absence of splenomegaly and lymphadenopathy. So basically, in aplastic anemia, it is divided into two, in which the most common one is the acquired type aplastic anemia, comprising 80 to 85%, and 15 to 20% would be inherited type aplastic anemia. As I've said earlier, in aplastic anemia, there would be marked reduction of all types of cells. There would be pancytopenia in the bone marrow and in the peripheral circulation, thus leading to three major complications of aplastic anemia. The most common one, in which 40% of the patient manifests, is risk of bleeding. Patient might experience easy bruisability, gum bleeding, and episodic nosebleed or epistaxis. Another one would be signs and symptoms of anemia, since if there would be decrease in red blood cells, there would be anemia. So what are anemia symptoms? Or we have fatigue, headache, yellowish skin, or commonly called as jaundice. We have irregular heartbeats. We have chest pain. We also have cold, clammy skin and pallor. The patient also experiences dizziness, since we know that red blood cells has the capacity to carry oxygen. We also develop leg cramps, insomnia, and etc. We also have are at risk of infection, in which it is present in less than 5% of the patient because of the decrease in the white blood cells, which are the soldiers of our body that defend us from any microorganisms or pathogens that invade our bloodstream. So aside from the bone marrow aspiration or bone marrow biopsy, how do we diagnose aplastic anemia? So we have three common parameters that we are observing in the CBC. we have the hemoglobin of less than 100 gram per liter, we have the neutrophil count of less than 1.5 times 10 raised to 9 per liter, and platelet count of less than 50 times 10 raised to 9 per liter. So if the patient presents with at least 2 out of the 3 parameters, the hemoglobin, neutrophil, and the platelet count, this could be a high suspicion for aplastic anemia. So there are also diagnostic criteria for aplastic anemia. So we are using bone marrow, neutrophil, platelet count, and other parameters such as hemoglobin and reticulocytes. So we have NSAA, we have non-severe aplastic anemia, severe aplastic anemia or the SAA, and VSAA, in which we have very severe aplastic anemia. So kindly familiarize yourself with the parameters and the values of diagnosing aplastic anemia. We have NSAA, SAA, and VSAA. As shown in this slide, this is showing a bone marrow biopsy. In letter A, this shows a normal cellularity of the bone marrow in which it has approximately 3:1 ME ratio. In image B, this shows hypocellular. As you can see, there is marked reduction of the cellular components if we compare it to image letter A. In the peripheral blood of patients with aplastic anemia, as you can see, there is an occasional macrocytes and absence of white blood cells and platelets. As I've mentioned a while ago, in aplastic anemia, there would be pancytopenia. So when we say pancytopenia, there would be an overall decrease in all cell types in both the bone marrow and in the peripheral blood. So here are the characteristics that you must remember in aplastic anemia. So we have hypoplastic or aplastic bone marrow. We have occasional presence of lymphocyte and plasma cells, megakaryocytes, which are precursors for platelets, are absent in the bone marrow. There would be no increased number of immature cells or the band cells. And in the bone marrow biopsy or bone marrow aspirate, there would be patchy areas of cellularity as shown in image B. Shown in this slide are other laboratory findings we can see in aplastic anemia, in which we have the MCV or the mean corpuscular volume, which can be increased or normal, and this aplastic anemia was classified as normocytic normochromic type of anemia. If you could recall in Hematology 1 discussion, I've mentioned this mnemonics AHA or AHA, in which these are classified as normocytic normochromic anemia. So aplastic anemia belongs to that AHA, so it is normocytic normochromic anemia. So we have also reticulocyte count and reticulocyte production index, which are decreased in aplastic anemia. And the red blood cells and platelets can assume normal appearance, where shown in the rightmost image. For the iron level and transferrin saturation, these are usually increased. This is due to decreased iron use for erythropoiesis. That is why the transferrin saturation is increased. For the hemoglobin F, this is elevated in some of the patients and is believed to be associated with better prognosis. As lectured on your immunology and serology, we have CD34 surface antigen, which are usually expressed by hematopoietic stem cells and early progenitor cell compartment. So in the presence of aplastic anemia, there would be marked reduction of the CD34 surface antigens, and there would be increase in the FAS or the FAS receptors. So if you can recall, the FAS receptors are used in apoptotic pathway. So if there is increase in FAS receptor, this only means that there would be increased activity of apoptotic or apoptosis or cell death of the cells. Now let's further discuss the mechanisms or the pathophysiology of development of aplastic anemia. So here are the following etiologies. I've mentioned that cytotoxic drugs such as doxorubicin, busulfan, chloramphenicol, chemicals such as benzene, which are commonly used in histopathology, radiation as a treatment, or any radiation in the exposure to environmental radiation, etc. And we also have viruses. These all causes direct damage. So it causes direct damage to the DNA of the hematopoietic stem cells and progenitor cells. So this would result to alteration of the ability of the cells to proliferate or to differentiate into mature ones. and eventually will lead to apoptosis or cell lysis or cytolysis. Another mechanism would be autoimmune mechanism, in which there would be development of mutation or alteration of the stem cell antigens that would eventually result to disruption of immune regulation mechanism. So if there are mutation of stem cell antigens, this would induce expression of abnormal or new antigens, and then there would be exposure of hidden antigens or induce an immune response that can cross-react with self-antigen, causing autoimmune mechanism of developing aplastic anemia. For the disruption of the immune regulation, so there would be reduction of the regulatory T cells. So let me just remind you of the purpose of the regulatory T cells. So from its name, regulatory, it regulates the immune system. So it regulates the autoreactive T cells. For instances that there would be reduction of regulatory T cells, there would be decreased suppression of the autoreactive T cells, which will eventually lead to autoimmune diseases. So for the immune-mediated, these are the mechanisms. The CD8 positive T lymphocyte will be activated and will proliferate and will be synthesizing cytokines such as interferon gamma and tumor necrosis factor alpha, in which the effect of these cytokines is to inhibit hematopoiesis and induce apoptosis, so increase cell death. There would be also increase in TNF-alpha in CD34 positive stem cells and progenitor cells. So endpoint would be there would be reduced stem cell compartment and or progenitors, eventually leading to bone marrow failure. So if a patient is diagnosed with having aplastic anemia, they could have complications. As discussed earlier, we have infection due to decrease in the white blood cells. There would be bleeding, which is the most common one. And there would be problems of iron overload from repeated transfusion, since if you have aplastic anemia, so you'll be anemic, so you need blood transfusion. So the side effect of massive or repeated transfusion would be iron overload. So for the prognosis of aplastic anemia is usually dependent on the severity of the marrow damage. So this could be assessed by your CBC and your bone marrow aspirate or bone marrow biopsy. So they say that initial blood count and response to therapy during the first few months of treatment are important prognostic factors. So these are the parameters that our physician take into account. Another, which the gold standard for aplastic anemia would be the bone marrow transplantation, in which it gives a long-term survival rate of up to greater than 60%. Generally, here are the management of aplastic anemia. So we have discussed bone marrow transplantation, which offers greater than 60% survival rate. We also give anti-lymphocyte globulin, in which this decreases number of activated T cells, and cyclosporin, which inhibits T cell function, and thereby suppressing the autoimmune reaction against the stem cells. As we said earlier, that development of aplastic anemia can have both from suppression of the bone marrow function and autoimmune mechanisms. We also have single donor platelets, since, as I've mentioned a while ago, that in aplastic anemia there would be thrombocytopenia. Antibiotics, because the patient with aplastic anemia is very susceptible in developing infection because of the decrease in the white blood cells or leukopenia. And we also give supportive care for patients with aplastic anemia. So now let's proceed to the different types of aplastic anemia, in which I've mentioned a while ago we have acquired type of aplastic anemia and inherited type of aplastic anemia. So let's first discuss the acquired type of aplastic anemia. Acquired type aplastic anemia can be categorized as either idiopathic or secondary acquired aplastic anemia. So for the idiopathic, which comprises 70% of acquired aplastic anemia, so these anemias have unknown cause. For the secondary type, which comprises 10 to 15% of the acquired aplastic anemia, are aplastic anemia that is associated with unidentified cause. This might be due to environmental or genetic differences. So based on epidemiology, 1 in 500,000 patients in North America and Europe are diagnosed with acquired type of aplastic anemia. And in Asia and East Asia, there is a higher chance, 2 to 3-fold risk of having acquired type of aplastic anemia. So for the peak age for the occurrence of acquired aplastic anemia, it could occur at any age, but peak age should be 15 to 25 years old. So these also have no gender predisposition. So as you can see in the picture, this is a bone marrow biopsy for acquired type of aplastic anemia, in which there would be increased infiltration of fat cells or adipocytes compared to the cellular precursor cells that are color violet. As mentioned in the previous slide, that acquired aplastic type of anemia can be due to environmental exposure or genetic predisposition. So exposure to drugs and chemicals such as your chloramphenicol, which is a classic drug associated with marrow aplasia, in which if we observe under the microscope, there would be presence of vacuolated cells in the bone marrow, especially the erythroid series. So the effect of your chloramphenicol is usually dose-related, time-dependent, and is usually reversible. So if we get rid, or if the levels of the chloramphenicol is decreased on your blood, so the appearance of the erythroid cells will go back to normal. We also have benzene, which is commonly used in histopathology, and we also have hydantoin, which is a type of anticonvulsant, which can cause acquired type of aplastic anemia. We also have sulfonamides, and then we also have insecticide and pesticide, which is usually suppressing the bone marrow in a predictable or dose-dependent manner. And then we also have radiation, in which it damages the bone marrow stromal cells and affects cell-to-cell interaction, thus resulting to a decrease in growth response of the bone marrow in tissue culture. So radiation is not always therapeutic, but it could also cause acquired type of aplastic anemia. So dosing of radiation is very important. So in cases that there would be the high amounts of radiation, such as in Chernobyl Islands, so this causes damage to the microenvironment in the bone marrow, which is usually reversible. So, for example, in the Chernobyl Island, if due to the high levels of radiation there, so after exposure to acute exposure to radiation, usually the first thing that, or the first parameter that will be affected is the reticulocyte count. So the reticulocyte count usually falls, but the red blood cells slowly declines because of their long survival. As we all know that the lifespan of our red blood cells is 120 days. So for the first few hours of exposure to radiation, there would be neutrophilic leukocytosis as a result of shift from the pool or the marginal pool, and probably from the bone marrow storage pool of the neutrophils, since as I've discussed in your hematology 1, your neutrophils have bone marrow pools or bone marrow na storage. There would be also fall in the lymphocyte after the first day, and this would be responsible for the early leukopenia, so decrease in the white blood cells, because based on literatures, your lymphocytes are very sensitive to irradiation and are directly killed. So after 5 days or more of exposure to your radiation, your granulocyte begins to fall and the platelets decrease later part. So the platelets are often the last and the least sensitive for radiation, and is usually return normal during the recovery phase. Also take note about the viruses that are occasionally associated with acquired type aplastic anemia, in which we have Epstein-Barr virus, HIV, hepatitis, and human parvovirus B19, which usually infects the erythroid replicating cells. In patients having human parvovirus B19 infection, usually they have they are presenting with anemia, because again, parvovirus B19 infects erythroid replicating cells, which will eventually mature to a erythrocyte. So for the genetic variation or predisposition, they impart genetic susceptibility to aplastic anemia, and as well as contribute to severity. So if you are genetically susceptible individual, you can easily develop acquired type aplastic anemia. We could also have a variation in the immune responses and the metabolic enzymes which will exhibit genetic polymorphism. Some of the miscellaneous etiologies for acquired type anemia would be your overt hepatitis, paroxysmal nocturnal hemoglobinuria, also with myeloid disease, marrow wherein you have or you can exhibit marrow hypofunction in those cases. Also in pregnancy, you can get or develop acquired type aplastic anemia. So all of these, you should remember your drugs and chemicals, your chloramphenicol, benzene, and radiation, also the viruses, and for the genetic predisposition. Shown in this slide are the selected drugs reported to have rare association with idiosyncratic aplastic type of anemia. So what do we mean by idiosyncrasy? So this refers to rare reaction not related to the mechanism or the primary mechanism of action of the drugs. So this idiosyncratic type of aplastic anemia usually manifests only on susceptible individuals. So these are the drugs listed that are found to have idiosyncratic reaction. So we have anti-arthritics such as your penicillamines, antibiotics such as your chloramphenicol and sulfonamides, anticonvulsants, antidepressants, and anti-diabetic agents. So these all causes suppression of the bone marrow, thereby causing anemia. So as I will emphasize that the aplasia or the acquired type aplastic anemia is not the primary action of the drug. These are just idiosyncratic reactions or side effects related to the action of the drug. So not all individuals taking these type of drugs will develop acquired type aplastic anemia or idiosyncratic type aplastic anemia. We have already identified the different etiologies of acquired type aplastic anemia. So now let's proceed to the pathophysiology. So for the acquired type aplastic anemia, approximately one-third of the patient with acquired type aplastic anemia have shortened telomeres in their peripheral blood granulocyte compared with age-matched controls or so in the studies. So what's the action of telomeres? So these telomeres are created by the telomerase enzyme, in which this enzyme complex repairs and maintains the telomeres that caps your chromosome. As you can see in the left image, the color blue would represent your chromosomes, and the gray portion would be the telomere that caps the chromosome. So normally, in senescent or old individuals, the telomeres tend to be depleted. But if you are a child or having a young age, so this normally is not shortened. So if you have shortened telomeres, so the cell would undergo proliferation arrest and eventually will lead to premature apoptosis, thus causing decrease in the number of cells, or in this case, decrease in the granulocyte. So this might be due to also for stress hematopoiesis, in which there is an increase in progenitor cell turnover, and then the telomeres become shorter with each cell division. So a depletion on the telomere would eventually result to proliferation arrest and premature apoptosis. Also, if you have shortened telomeres, these occur most often in patients with those with pancytopenia who do not respond to immunosuppressive therapies. Again, if you have shortened telomeres, what are the effects? There would be proliferation arrest and premature apoptosis, thus causing a decrease in the cell formation or cell division. Now let's discuss about the treatment for acquired type aplastic anemia. So we have the HSCT or the hematopoietic stem cell transplantation, in which this is a treatment of choice for less than 40 years old with HLA identical sibling. Another, we have immunosuppressive therapy or the IST, in which this is the treatment of choice for greater than 40 years old without HLA identical siblings. We also employ supportive therapy. Again, for the HSCT, this is the treatment of choice for less than 40 years old with HLA identical sibling. And we have IST for greater than 40 years old without HLA identical sibling. So for patients having HSCT plus identical sibling, 91% of the children might have good prognosis. 74% of adults can achieve 10-year overall survival. For HSCT with HLA match unrelated donor, the prognosis is also good. We have 75% for the children and 63% for adults. For patients having immunosuppressive therapy or IST, 75% of children and 63% of adults can achieve 10-year survival. Now let's proceed with the inherited type aplastic anemia. In this type of aplastic anemia, there is slow manifestation of the disorder at an early age and may be associated with physical malformation. So take note, these present at an early age and may present physical malformation. In this presentation, we'll be discussing three most common type of inherited type of aplastic anemia, in which we have Fanconi anemia. Next, we have Dyskeratosis Congenita, and lastly, we have Shwachman-Bodian-Diamond syndrome. So let's discuss first Fanconi anemia, which is termed as the most common inherited aplastic anemia, in which it has epidemiologically it has 1 to 5 cases per million. And then this was discovered and described by Dr. Guido Fanconi. So this syndrome is discovered in three brothers with presenting symptoms such as skin pigmentation. So there is hypopigmentation, short stature, and hypogonadism. So these are the key features of Fanconi anemia. We have hypopigmentation, short stature, and hypogonadism. So this is an autosomal recessive disorder in which there is a chromosomal instability disorder characterized by three. We have aplastic anemia, physical abnormalities, which are the hypopigmentation, short stature, and hypogonadism, and it has a cancer susceptibility. As shown here in the left image, this is just a picture showing the must-know information about Fanconi anemia, wherein we have DNA repair defect, in which is autosomal recessive. And as mentioned a while ago, it has a cancer susceptibility in which it is having an increased risk for AML, solid tumors, and aplastic anemia. So for the laboratory findings for Fanconi anemia, this is usually a macrocytic type of anemia with elevated fetal hemoglobin or the hemoglobin F. Then these are characterized by short stature, low set ears, similar to your Down syndrome. We have deafness, strabismus, skin hypopigmentation, renal abnormalities, and for the treatment of this would be bone marrow transplantation. So another feature for this Fanconi anemia is that they present with absent or hypoplastic thumb. So if you see patients or individuals having absent or hypoplastic thumb, so further investigate for the presence of Fanconi anemia. So take note for the key features. We have hypopigmentation, short stature, and hypogonadism in the presence of aplastic anemia, and increased risk for cancer susceptibility, so AML, solid tumors, and other cancer entities. So this slide shows the manifestation of Fanconi anemia, in which there are physical malformation that may be present at birth, since this is an inherited type of aplastic anemia. And also there are hematologic abnormalities, but these hematologic abnormalities may not appear until older childhood or adulthood. So the symptoms associated with Fanconi anemia are the following. We have skeletal abnormalities. We have skin pigmentation, which is the hypopigmentation. Short stature, abnormalities in the eyes, as mentioned a while ago. We have strabismus. We also are susceptible for kidney abnormalities and genital abnormalities. Patients having Fanconi anemia are usually having low birth weight, and may have developmental delays. We also have pancytopenia as a manifestation of your aplastic anemia and usually become apparent at 5 to 10 years of age, but some patients may not present until adulthood. So what are the parameters that we are looking or when suspecting for Fanconi anemia? So in your CBC or your peripheral blood smear, we can see macrocytic red blood cells, which is usually the first detected abnormality in the CBC. But also in other books, they could be macrocytic normochromic type of anemia. So as mentioned in the picture or shown in the picture on the slide 1 of Fanconi anemia, they have increased level of your hemoglobin F and I antigen. And if we request for a diagnostic test such as your chromosomal breakages, there are presence of random breaks and rearrangement that are characteristically seen on the blood lymphocyte as well as in the marrow cells of patients having Fanconi anemia. So shown in this slide, on the right side picture is the chromosomal breakages of a patient of having Fanconi anemia. Other special tests that are requested when suspecting Fanconi anemia would be the osmotic fragility test and the ESR result, which will reveal an increased OFT and ESR result. So take note, the first abnormality that is detected in patients having Fanconi anemia is presence of macrocytic red blood cells and increased hemoglobin F levels. So in vitro examination of the specimen from a Fanconi anemia patient, there are chromosomal breakages as we mentioned a while ago, which may become more prominent when cultured cells are challenged with alkylating agents and DNA cross-linking agents such as your mitomycin and dipoxybutane. So these agents are used if we are testing for the chromosomal breakages. We mentioned a while ago that patients having Fanconi anemia will have growth retardation and delays in their development. Also, they have absent thumb due to the chromosomal breakages. They are also having stem cell failure and they are at risk for developing cancer. So on the next slide, we'll be discussing what type of cancer are most common in Fanconi anemia. So take note, chromosomal breakages are prominent on the cultured cells when exposed to mitomycin and diepoxybutane. And they are increased or they have increased risk for developing carcinoma. So based on genetic studies, Fanconi anemia has a genetic mutation on the FANCA gene. So this FANCA protein is one of the proteins known in the FA core complex. So they make instructions for making protein that is involved in the Fanconi anemia pathway. So when there is a mutation in the FANCA gene, the pathway will be turned on or activated. And when the DNA replication is blocked, this might be due to the DNA damage or the DNA breakage that is present on Fanconi anemia. So, the FANCA protein complexes and activates two proteins. We have the FANCD2 and the FANC1, and by attaching to the ubiquitin to each one of them. So, the activation of these two proteins, the FANCD2 and the FANC1, will attract DNA repair proteins to the area of the DNA damage so that the error can be corrected and the replication of the DNA can continue. But in the presence of mutation for the FANCA gene, so there would be a mutated FANCA protein that will not be able to attach to your two proteins mentioned a while ago, your FANCD2 and your FANC1. So there would be less DNA repair. So if there is less DNA repair, there would be more DNA errors and would eventually cause DNA damage. So if the DNA damage or the damaged DNA was replicated and not corrected, so this could cause genetic mutations. For in this case, it would cause Fanconi anemia for the mutation of the FANCA gene. For the treatment for Fanconi anemia, we have hematopoietic stem cell transplant and supportive treatment. So for the supportive treatment, we administer cytokine, the GCSF and the GM-CSF, which will eventually cause increase in the granulocyte and the monocyte series. For the prognosis of Fanconi anemia, this usually causes 90% bone marrow failure, and one-third of the patient will develop myelodysplastic syndrome or acute myelocytic leukemia for usually in the median age of 14 years old. Another striking characteristic for Fanconi anemia is the development of solid tumors. 25% will develop solid tumors. Most commonly, squamous cell carcinoma type of tumor of the head and neck, anogenital region, and the skin. So take note, 25% of Fanconi anemia patients will develop solid tumor at the median age of 26 years old. If Fanconi anemia is left untreated, death usually occurs at 20 years of age. The next type of inherited type of your aplastic anemia would be your DC or your Dyskeratosis Congenita, in which it manifests as mucocutaneous abnormalities as shown in the picture. We also have bone marrow failure and abnormal skin pigmentation with dystrophic nails. And then we have oral leukoplakia, in which leukoplakia means that the mucous membrane is characterized by white patches, especially seen on the cheek, tongue, vulva, and penis. There could also be multiple organ abnormalities. So as shown in the picture, so we have your letter B, we have dystrophic nails, and then on your letter C, we have oral leukoplakia on your tongue and in your cheek. So that's on the right side of the slide. Same as your acquired type aplastic anemia, so your Dyskeratosis congenita patients have chromosomes with short telomeres. So there is mutated telomerase complex genes, in which we have mutated TERT, which is the telomerase RNA component, the TERT or the telomerase reverse transcriptase, and the TINF2 or the component of your shelterin. So take note also for the mutation of this protein, dyskerin, which is used to stabilize the telomerase complex. So when the telomerase shorten, the cell division stops, and then when the telomerase shortens through aging, this person is at high risk of chronic diseases, since, for example, your telomerase of your granulocytes prematurely shortened, so you have cells that are easily dying, or there would be activation of your apoptotic pathway, so there would be increased turnover of your granulocytes, so thereby predisposing you to chronic infectious diseases. So take note, Dyskeratosis congenita is or has the same chromosome with short telomeres, same with your acquired aplastic anemia, and unique for your DC would be the mutation of your dyskerin. So easy to remember, dyskerin for Dyskeratosis congenita. Shown in here are the laboratory findings that are seen on your Dyskeratosis congenita or DC. We also have macrocytic red blood cells similar to your Fanconi anemia. We also have pancytopenia, increased hemoglobin F similar to your Fanconi anemia. But the difference between your Fanconi and your Dyskeratosis congenita is that in your DC, there is no chromosomal breakages. When we compare it to your Fanconi, we have chromosomal breakages. On your fluorescence in situ hybridization or your FISH test, there is also presence of your short telomeres. For the Dyskeratosis congenita, as mentioned, they have shortened telomeres. For example, in several WBC subsets, specifically on your naive T cells and B cells. So if you have shortened telomeres, again, your cells are easily aging. So there is an increased cell turnover, thereby predisposing the individual to chronic diseases. So for the treatment for DC, we administer androgen therapy, in which this produces transient response in 50 to 70% of the patient. But
it does not halt or stop the progression of the bone marrow failure. So the median survival of patients having Dyskeratosis congenita is approximately 42 years. In patients with Dyskeratosis congenita, treatment with bone marrow transplantation has not been optimal because studies would show that there is a high incidence of fatal pulmonary fibrosis and also vascular complication as compared to your Fanconi anemia, in which they benefit bone marrow transplantation. Now let's proceed to the third type of your inherited aplastic anemia, which is the Shwachman-Bodian-Diamond syndrome, in which this is an inherited multi-system disorder that is an autosomal recessive disorder characterized by your pancreatic insufficiency, peripheral blood cytopenia with decreased pancreatic enzyme secretion. So this causes, the pancreatic insufficiency causes gastrointestinal malabsorption, which is typically presents on early infancy. We also have cytopenia, in which, for example, there would be neutropenia and immune dysfunction, which predisposes the individual to severe infection and sepsis. For the skeletal abnormalities, there would be delayed bone maturation, thus predisposing the individual of having short stature similar to the above mentioned inherited aplastic anemia types. 50% also are predisposed to failure to thrive, and also they are predisposed to hematologic malignancies. According to literature, 90% of patients are having SBDS gene mutation, in which this maintains ribosome metabolism and mitotic spindle stability. So, similar to your Dyskeratosis congenita and acquired aplastic anemia, patients having Shwachman-Bodian-Diamond syndrome are also having short telomeres on genetic studies. So, how do we diagnose Shwachman-Bodian-Diamond syndrome? So, we have the following laboratory findings. We have cytopenia, so decreased level of all blood cell types. And we have normocytic to macrocytic red blood cells. Also, the same with the other types of inherited aplastic anemia, we have increased hemoglobin F levels. And usually, upon bone marrow aspiration or bone marrow biopsy, there would be bone marrow hypocellularity. Then, the 72-hour fecal fat excretion is also increased because of the pancreatic insufficiency. And then, same as your serum trypsinogen and isoamylase will also be decreased since you have pancreatic insufficiency. Also, an adjunct laboratory test would be the sweat chloride test, which is normal. So, nearly all patients with SBDS or your Shwachman-Bodian-Diamond syndrome have neutropenia. As I've said earlier, number one laboratory finding would be cytopenia. So, there would be neutropenia of less than 1.5 to 3 times 10 raised to 9 neutrophils per liter. And then, half of these patients or 50% of these patients will develop anemia, thrombocytopenia, and a portion of it or 1/4 of it will develop pancytopenia. So, what's the importance of your sweat chloride test? For your Shwachman-Bodian-Diamond syndrome, so this is, the sweat chloride test is normal in comparison with your cystic fibrosis or your CF, which has similar malabsorptive presentation. So, patient with cystic fibrosis also present with pancreatic insufficiency and malabsorption. But patient with cystic fibrosis has an abnormal sweat chloride test as we compare it to your SBDS patient, which has normal sweat chloride test. So for the treatment and prognosis of your SBDS, we give GSCF for neutropenia. So to address the neutropenia, we give granulocyte colony stimulating factor. And then we give transfusion support to address the anemia and thrombocytopenia of the patient, and enzyme replacement for the pancreatic insufficiency. Also, allogenic bone marrow transplantation can be recommended in patients with severe pancytopenia, on patients developing acute myelocytic leukemia or myelodysplastic syndrome. So for the overall survival of your SBDS, there would be 60 to 65% 5-year overall survival for these patients. So take note, GCSF for addressing the neutropenia, transfusion support to address anemia and the thrombocytopenia, and enzyme replacement for addressing the pancreatic insufficiency seen in these patients. So this table, 21-3, are the key characteristics of inherited or congenital bone marrow failure anemia, which is lifted from your book, RODAC. So first, we have Fanconi Anemia, Dyskeratosis Congenita, and your SBDS, and your diamond blackfan anemia. So take note for the genetic differences, the appearance in the peripheral blood, in which majority of them present with pancytopenia, and also for the bone marrow, they exhibit hypocellular with decrease in all cell lines because they are pancytopenic. And take note for the laboratory test result of each type of your bone marrow anemia and the subsequent clinical findings. So on the previous slide, we mentioned the key features of each of these bone marrow failure anemia. So this table 21-2 are the differential diagnosis in patients having pancytopenia. So we have the following differential diagnosis before we diagnose the patient with aplastic anemia. First, we rule out the presence of your PNH or your paroxysmal nocturnal hemoglobinuria. We have myelodysplastic syndrome or your MDS, megaloblastic anemia, acute leukemia, and hairy cell leukemia. But the unique features for your aplastic anemia would be on peripheral blood, there would be no mature or there would be no immature WBCs or red blood cells, and there would be decrease in retic, and also there would be macrocytosis as shown of increase in the MCV and the CBC, and it could also be normal. So again, there would be no immature WBC or RBC because in aplastic anemia, we mentioned that in aplastic anemia, there would be pancytopenia. So the bone marrow also present with hypocellular or hypocellularity as we compare to the other differential diagnosis in which they are exhibiting erythroid hyperplasia in PNH, hypercellularity in your MDS and megaloblastic anemia, the same as your acute leukemia and hairy cell leukemia. For the clinical findings, strikingly, for aplastic anemia, splenomegaly are usually absent. When we compare it to your other differential diagnosis in which splenomegaly may be present. Also, on your laboratory test result, for your acquired type aplastic anemia, so PNH cells may be present and your chromosome abnormalities may also be present. As mentioned a while ago, we have your for Fanconi, your Dyskeratosis, and your SBDS. Now we go to the other forms of abnormalities that may present as bone marrow failure. So first, we have your pure red cell aplasia or your PRCA, in which there is decreased erythrocyte precursor in a normal bone marrow. So this may be acquired or a congenital. So there would be, again, selective and severe decrease in the erythrocyte precursors in otherwise normal bone marrow. So the decrease in the erythrocyte precursors would lead to severe anemia since there would be decrease in mature red blood cells. There would be also reticulocytopenia, but strikingly, there would be normal WBC and platelet count. As the name implies, it's pure red cell aplasia. So there would be decrease in the erythrocyte or the red blood cell precursor in the normal bone marrow. So there are wide range of etiologies for pure red cell aplasia. It could be from your anti-thrombopoietin or rather anti-erythropoietin antibodies that attacks your erythropoietin, which as we tackled in hematology 1, it promotes the development of red blood cells and which is called your erythropoiesis. And then we also have another etiology, IgG antibodies, which attack your erythropoietin and also your bone marrow cells. We have cytotoxic T lymphocyte, which attacks the cells, also with your isoagglutinin and warm autoantibodies. So the presence of these several etiology or your abnormalities could cause your pure red cell aplasia and would reflect um, decrease in the red blood cell or erythrocyte precursors and would lead to severe anemia and reticulocytopenia. And also, we must not forget the virus that could attack your erythroid precursors, which I've mentioned a while ago, which is the parvovirus B19, which usually affects the erythropoietic precursors and eventually leading to pure red cell aplasia. So we mentioned that your pure red cell aplasia can be either acquired or congenital. So for the acquired, it is subcategorized as either primary or secondary. So for the primary, usually the cause is idiopathic or autoimmune. So these are unknown causes. For the secondary, usually there is an association to underlying thymoma, other hematologic malignancies such as your also the presence of your solid tumors, infection, presence of chronic hemolytic anemia, other collagen vascular diseases, and exposure to drugs or chemicals. So, for the treatment for your acquired PRCA, these are directed to the underlying condition in the case of your secondary acquired pure red cell aplasia. Also, we administer immunosuppressive therapy such as your cyclosporine and your corticosteroids or your steroids, in which literature would say that there is a higher response rate to your cyclosporine, up to 65 to 87%, compared to your corticosteroid, which only has 30 to 62% of response. Also, we have this what we call TEC or your transient erythroblastopenia of the childhood, which is similar to your diamond black fan anemia. But in your TEC, this is usually seen on young children with history of viral infection. So for the treatment of this type of your TEC would be red cell transfusion for support. Then red cell are transfused because ang kulang sa patient with having which has TEC is only red blood cells. So we give what is lacking. So the normalization of your erythropoiesis usually occurs within weeks. So on the previous slide, I've mentioned about your DBA or your diamond black fan anemia. So what is DBA? This is a congenital erythroid hypoplastic disorder that is commonly seen during early infancy. So mga bata ang commonly affected ng diamond black fan anemia. So it is stated there that it has erythroid hypoplasia. So there is hypoplasia means decrease of erythroid precursor in the presence of normal cellularity of the myeloid and megakaryocyte precursor. So if we look on your CBC, there would be normal leukocyte and platelet count but decreased erythrocyte. So there would be also presence of ribosomal protein mutation, which is your RPS19 gene. Take note of the RPS19 gene. And usually, the appearance of this type of anemia would be normochromic macrocytic type of anemia. But in RODAC, they say that is normochromic normocytic type of anemia. So here are the clinical features that is commonly seen on your diamond black fan. We have physical and physical abnormalities, which are patients having craniofacial dysmorphism, short stature as seen in the image, and also, as you can see, there is a neck and thumb malformation. But in this case, there would be no renal abnormality. So how do we diagnose diamond black fan anemia? So here are the following laboratory findings we can see. So we have normocytic to macrocytic type of anemia. We also see reticulocytopenia. And on the bone marrow, there would be normal cellularity of the myeloid and megakaryocyte precursor. But strikingly, there is hypoplasia of your erythroid cells. So hypoplasia of your pronormoblast. So there would be also increase in hemoglobin F and erythrocyte ADA are increased. So I've mentioned that there is an increase in hemoglobin F and erythrocyte adenosine deaminase, then if we compare this to your TEC, which is similar to your diamond black fan anemia, the result of your hemoglobin F and your ADA will be normal. So how to differentiate between diamond black fan and TEC? By the use of your hemoglobin F and erythrocyte ADA, in which in diamond black fan anemia, there would be increased hemoglobin F and increased erythrocyte adenosine deaminase activity. For the treatment and prognosis, usually we give red blood cell transfusion to address the anemia of the patient. And usually patient will respond to corticosteroid therapy. 50 to 75% will then with patient with diamond black fan will respond. But there are side effects for the corticosteroid use with the long-term use, including immunosuppression and developmental and growth delays. There would be also overall survival of 75% for 40 years. And then there is 90% overall survival in patients younger than 10 years old with transplanted match-related donor, and 80% in those with match-unrelated donor. So that's for the bone marrow transplantation. So 90% for patients younger than 10 years old for match-related donor, and 80% for match-unrelated donors. So I lifted this table 19.4 from RODAC, in which this table distinguishes the characteristic of your DBA from your TEC by the following parameters. We have erythrocyte adenosine deaminase at the diagnosis. We have MCV, or the mean corpuscular hemoglobin, at diagnosis and in remission, and hemoglobin F at diagnosis and in remission. As shown in here, there is an marked increase in your the following parameters for your DBA as compared to your TEC, which is normal to slightly increased only. So let's proceed with another type of bone marrow failure, which is named as congenital dyserythropoietic anemia, or the CDA. When we say congenital, the disease starts at the time of birth, and this erythropoiesis means that there is ineffective erythropoiesis. So these are characterized by dysplastic changes, meaning there are presence of cells that are abnormal within the bone marrow. So the CDA is characterized by refractory type of anemia, so it doesn't usually respond to treatment, as the word says, refractory. And then we also have reticulocytopenia, hypercellular bone marrow, as compared to your other types of anemia mentioned a while ago, which has hypocellular bone marrow, and also we have ineffective erythropoiesis. So CDA has three types. We have CDA 1, 2, and 3. So we will be discussing them one by one on the succeeding slides. So we have CDA type 1, in which this has a mutation of your CDAN1 gene and manifests as mild to severe type or chronic type of anemia. So what are the key features for CDA1? These patients will manifest malformation of the fingers and toes, will have pigmentation of the skin, brown pigmentation of the skin, and also have neurologic defects. For the red blood cell morphology for this type of CDA, this has poikilocytosis, presence of basophilic stippling, and Cabot ring. So I hope that you can still remember the appearance of your basophilic stipplings and your Cabot rings. For the bone marrow appearance of the cells, we have erythroblast morphology. So CDA1 has megaloblastoid with internuclear chromatin bridge or nuclear strands, as shown in the image. Parang meron siyang sinulid that connects two nucleus between two erythroblasts or between two nuclei in a single cell. So this show only depicts an ineffective erythropoiesis because generally dapat walang strand that connects the two nuclei. So also it has a spongy heterochromatin with Swiss cheese appearance of your chromatin. Next, we have CDA type 2, in which this has a mutation on your SEC23B gene and has the following laboratory findings. Similar to your CDA type 1, this has poikilocytosis and presence of basophilic stippling, but now associated with anisocytosis. For the laboratory test that can be requested to confirm the presence of your CDA type 2, we can request for your sucrose hemolysis test and HEMPAS, or also called as hereditary erythroblastic multinuclearity with positive acidified serum. So the CDA type 2 is characteristically positive for these two types of laboratory tests. Take note also for the appearance of the cells of your CDA type 2. The last type of your CDA is your CDA type 3, in which the bone marrow has a megaloblastic development of giant erythroblasts with nuclei up to 12 in number. As depicted in the picture, the nucleus of the erythroblast can reach up to 12 in number. So in this case, there is 1, 2, 3, 4, 5, 6, 7 nucleus in one erythroblast. So this is the characteristic histopathologic appearance of your CDA type 3. I lifted this table 19.3 from your RODAP, in which this discusses the types of your CDA. So from CDA 1 to 3. So for your CDA 1 has a mutation on your CDAN1, your CDA 2 has mutation on your SEC23B, and your CDA 3 will have a KIF23 gene mutation. Take note also that on peripheral blood, these manifest with anemia and reticulocytopenia. And then your CDA1 and CDA3 will have an increased MCV, so they are macrocytic, but your CDA2 will have normocytic type of anemia. So also unique to CDA1 is the presence of your Cabot rings, and from CDA1 to 3, they all have a presence of your basophilic stipplings. And on bone marrow examination, your CDA 1 to 3 will have hypercellular bone marrow with erythroid precursors present. The last disease entity that we'll be discussing for this discussion that causes bone marrow failure is the myeloprolific type of anemia, in which the bone marrow is infiltrated by metastatic cells, leukemic cells, fibroblasts, and other abnormal cells. So, to briefly discuss the pathophysiology for myeloprolific anemias, there would be infiltration of abnormal cells or abnormal tissue components. For example, I mentioned metastatic leukemic cells, fibroblasts, increased number of inflammatory cells in cases of multiple myeloma, leukemia, and lymphoma. And also in a disease state such as your lipidosis or storage disorders. So the infiltration of abnormal cells of the bone marrow will subsequently result to destruction and replacement of the normal hematopoietic cells. So if the normal hematopoietic cells are destroyed and replaced, so there would be now abnormal development of the normal cellular components that are seen in the peripheral blood. So again, what are the abnormal cells that could infiltrate the bone marrow? These are commonly from metastatic solid tumors, commonly from your lung, breast, and prostate. Inflammatory cells can be also implicated or found during miliary tuberculosis and fungal infection. So if there is infiltration of abnormal cells or tissue component, this will eventually result to destruction and replacement of the normal hematopoietic cells that creates the red blood cells, the white blood cells, and the platelets. So this will cause pancytopenia, so eventually leading to bone marrow failure. So when there is presence of your abnormal or malignant cells on your bone marrow, for example, in this case, we have breast cancer and your small cell lung cancer cells that infiltrates the bone marrow, this causes bone marrow architecture disruption. And then this would eventually lead to premature release of the immature cells, your stem, your progenitor, your stromal cells from the bone marrow. And then they migrate to the spleen and the liver. But this spleen and liver are unfavorable for bone marrow or cell formation. So, what do we call the formation of blood components outside the bone marrow is what we call extramedullary hematopoiesis. So, the extramedullary hematopoiesis is usually less efficient when we compare it to your medullary hematopoiesis. So, hindi masyado gaanong marami yung cells na produce during extramedullary hematopoiesis. That is why in myeloproliferative anemia, there is cytopenia. Because, for example, kung ang activity ng medullary hematopoiesis is 100%, when we compare it to your extramedullary hematopoiesis, which is occurring on your spleen and liver, na for example, mga 50% lang. So, hindi niya makatch up yung demand ng cell demand ng body. So, in the complete blood count or CBC, and on peripheral blood examination, we suspect the presence of myeloproliferative anemia if we see the cryocyte, so teardrop cells. Presence of the cryocyte also differentiate the myeloproliferative anemia from your aplastic anemia. So, what do we mean, or what is the indication, or what is the importance of seeing the cryocyte in the peripheral blood smear? So, if we can see the cryocyte in the PBS, it usually means that parang yung architecture ng bone marrow is puno ng abnormal cells. So, usually dapat hindi sila squeezing out. So, parang ibig sabihin ng the cryocyte, nahirapan sila lumabas from the bone marrow due to the presence of your abnormal or metastatic cells. So, di ba, usually if ang red blood cells maglabas from the bone marrow, they are usually round in the form of your retics, and then, kaya nga sila tinawag na discocyte. So, also the presence of your nucleated red blood cells and immature myeloid cells, which is called erythroblastosis, might indicate the presence of myeloproliferative anemia. Because in myeloproliferative anemia, there would be immature release of premature cells. And also, there is a megakaryocytic fragmentation seen in myeloproliferative anemia. So this slide shows the parameters we use to diagnose or suspect for the presence of myeloproliferative anemia. So the myeloproliferative anemia is usually classified as normocytic to macrocytic normochromic type of anemia with increased reticulocyte count with out of proportion normoblast. And on the peripheral blood, immature neutrophils, even myeloblasts can be seen. And also the typical appearance of your platelet can be seen on the PBS. And on bone marrow aspirate or biopsy, there is presence of infiltrative cells. For example, in cases of metastatic carcinoma, multiple myeloma, and leukemia. So, infiltration of your abnormal cells or tissue components on bone marrow aspirate or biopsy. So, the presence of your infiltration of abnormal cells also differentiate myeloproliferative anemia from your aplastic anemia on bone marrow biopsy. So, if you see infiltration of abnormal cells, you can rule out your aplastic anemia. So, I think that's the end of the discussion. If you have questions regarding the topic, you can message me on Telegram, or if you want to further read about this topic, I lifted this discussion from your book, Rodak, and from other lecture notes. Thank you and God bless.